The idea is for me to set the stage for the other speakers that are going to be here today. International and country-level guidelines are available to guide the diagnosis and management of drug-resistant tuberculosis. However, we all know that challenges exist for the implementation of these guidelines. And so I want to highlight existing recommendations, challenges to guideline implementation, as well as the impact of these constraints. So these are my disclosures. I am an employee of Becton Dickinson. So when I think about effective TB management, I really know that it relies on proper diagnostics. And I think about kind of four major buckets, right? First, of course, is the clinical exam, where you want to have a thorough patient and clinical history, take into consideration risk factors, as well as a history of TB exposure, demographic incidents, and also medical conditions that could increase your risks for TB disease. I also think about sputum smear microscopy, which is the preliminary presumptive TB diagnostic. And then I also have a bucket for culture. Culture, of course, is the gold standard for bacteriological confirmation of TB, but it's also important for patient monitoring, and it's needed for phenotypic DST as well. And then last, of course, but not least, we're surging the era of nucleic acid amplification tests and also targeted next-generation sequencing. These allow for more rapid identification, earlier lab confirmation, and also ultimately leading to improved patient outcomes. But this also leads me to the first gap that I'm going to talk about today, and that is that not all presumptive TB is bacteriologically confirmed. So why is this important? Well, as part of the WHO standard on universal access to rapid TB diagnostics, if you look at step 3, benchmark 9, it actually says that individuals with bacteriology-confirmed TB should undergo universal DST. And therefore, countries that are embarking on interventions to detect and treat drug-resistant TB really need to establish laboratory capacity to perform phenotypic DST as well as genotypic, expand the capacity to monitor culture conversion of people as well. So it really is important to know that you have bacteriologically confirmed TB. So I wanted to take a moment also to talk about the drug resistance definitions, because treatment of TB has undergone significant changes over recent years. So we usually tend to think about wild-type TB when we're referring to susceptible TB bacteria or TB that has wider options for treatment. Next is drug-resistant TB, and this is defined as resistant to at least one first-line or SIRE anti-TB drug. We have multi-drug resistant TB, which are resistant to isoniazid and rifampicin. We also have individual rifampicin or isoniazid resistant strains as well. Pre-extensively drug-resistant TB is resistant to isoniazid and rifampin, plus any fluoroquinolone, and unfortunately, extremely drug-resistant TB is all of the above, and in addition, you're resistant to at least one other group A drug, such as bedaquiline or linezolid. So this brings me to the second gap, which is that second-line drug testing is not always performed in patients with rifampin-resistant TB. I'll talk a little bit about why it's important in the next slides. So there have been, of course, many tools, publications, guidance documents that have been developed, including guidelines for the detection and treatment of drug-resistant TB. There's model diagnostic testing algorithms, there are guidance for scaling up laboratory capacities, and I give some of these examples in the top of this slide from UCAS and WHO. I wanted to, though, highlight a couple of key takeaways for culture, molecular, and sequencing. So if you see here for culture, in addition to what I've already mentioned, it's the importance for patient treatment monitoring and being adaptable to testing new drugs. As molecular testing has expanded, moderately complex nucleic acid amplification tests are also now recommended as the initial diagnostic test for persons with signs and symptoms of pulmonary TB. And in 2023, the WHO standard also states that individuals with bacteriologically confirmed TB should receive testing for resistance to rifampicin. And yet we also see a need for molecular INH resistance, which I'll talk about in the next slides. Of note, sequencing may be used for respiratory samples and diagnosing resistance, but there's also a need for increased capability, lab skills, and resources for laboratories to implement these. So I wanted to mention a bit about rifampicin and isoniazid resistance. I don't want to get too into the details, but we all know that RPOB is the common gene containing mutations associated with rifampicin resistance. And when we think about isoniazid resistance, we really think about INHA and CATG. I may mention APHC here because it's known to have compensatory mutations, but by itself, it will not cause resistance to isoniazid. And so in our guidelines, we want to determine if there is INHA or CATG mutations in order to confirm or detect resistance of isoniazid. So why is detecting of isoniazid resistance important? Well, in 2022, there was an estimated 410,000 people who developed rifampin-resistant TB. But about 8% of TB patients worldwide are estimated to have rifampicin-susceptible but isoniazid-resistant TB. And so if we only stop at the rifampicin resistance, you may actually be missing those that have only isoniazid-resistant TB. And this really is impactful, right? So if we look at the comparison of treatment outcomes between those isoniazid-resistant TB patients and patients with drug-susceptible TB, so if you don't do that additional step, you may think, oh, I have a drug-susceptible TB organism, when in reality you don't. Studies have shown that those patients that are isoniazid resistant, that are on the WHO standard regimen, actually have worse outcomes. And as I've mentioned here, they have higher treatment failures, so 11% compared to 1%. It's pretty significant. They have a relapse in 10% versus 5%, and they have higher rates of acquired drug resistance, so 8% versus 0.3%. So I know that if I were a patient, I would like to know if my TB is isoniazid resistant because it will impact my own outcome. So that leads me to the third gap. Isoniazid-resistant first-line testing is often skipped. And so I think that it's important to test. Why is it important? Not only to detect the resistance, but understand the mechanisms underlying the resistance. Well, in isoniazid-resistant TB cases, when there's a specific INHA mutations detected in the absence of CATG mutations, increasing the dose of isoniazid is likely to be effective. Versus if you have isoniazid resistance, when a CATG mutation is present or is detected, then the use of isoniazid, even at a higher dose, is less likely to be effective. And so it really does impact how, what drugs you may prescribe a patient. And if the cases where you have both INHA and CATG mutations, it's an indication of high-level resistance. And so you really may have to think about a different drug treatment. So this is really one of the reasons why it's important not just to know rifampin resistance, but also isoniazid resistance and exactly what mutations that strain has. So going to TB treatment, as we all know, TB treatment is guided by drug susceptibility status. And I will not go through this table in detail. It's more of just to show that there are differences in drug resistance that require different recommended treatments. And it highlights why it is imperative that we need to do drug susceptibility testing in order to assign patients the correct therapy. In addition to knowing that, though, of course, there are other factors to be considered when deciding on the most effective drug regimen, if there are several regimens that are possible. These are including drug interactions, adverse events, any prior treatment histories, patient preference, and of course, access and cost of those drugs as well. And so this leads me to the fourth gap, which is treatment and monitoring and test of cure after treatment is often not done. And this is another reason why it's important to continue with liquid cultures, because they are important in the monitoring of patients as well. So it's not surprising that the WHO Global TB Report calls for universal access to direct drug susceptibility testing for TB to meet the target of 75% reduction in TB deaths. And to do this, healthcare systems must further strengthen laboratory capacities and implement wider use of diagnostic tests, those more sensitive, of course, than the smear microscopy. And the guideline update made in 2021 added 3 new classes of nucleic acid amplification technologies, and the most recent one updated also targeted NGS was added. So let's take a look of what they say and when to use these. So WHO recommends rapid techniques be used as the initial diagnostic test to detect TB and rifampin resistance, but it also says that follow-on testing for resistance to isoniazid and fluoroquinolones is important. And because of what I just said previously, I don't think it's only important, I think it's imperative that we actually should be doing that testing as well. They do state that in people with signs and symptoms of pulmonary TB, moderate complexity automated NATs, like the BD MAX assay, may be used on respiratory samples for detection of pulmonary TB, rifampicin and INH resistance, rather than culture and phenotypic DST. And they also mention a little bit about targeted NGS tests that do not replace existing rapid tests that are more accessible and easier to perform. So it really does depend on the burden, the need, your situation, your population, on the combination of tests that you want to select to diagnose and treat. I want to talk a little bit about targeted NGS as well, and I know I have Anita here, so she'll talk more in her presentation. But in people with bacteriologically confirmed pulmonary TB disease on respiratory samples, WHO recommends using TNGS, and also in people with bacteriologically confirmed rifampin resistance pulmonary TB disease as well. And I'm not going to mention all the drugs, you can read them on the slide. But they do say that if targeted NGS tests can be performed rapidly, they can be considered as an alternate initial option for prioritized populations. And so again, you really have to take into consideration what's your population, what is the need of where you are, and what is the capacity that you have as well. And so I took a look. There was an interesting actually study, because I was like, well, how are we doing with TNGS? In The Lancet in October 2024, there was a systematic review and meta-analysis done by Tina Schwab and colleagues. And they actually did a really nice job, I think, of kind of underlying where we are today. So this systematic review and meta-analysis included 53 countries. And sequencing, they concluded, was actually mainly done in the US, Western Europe, India, and China. Specifically, they said that targeted NGS is not being leveraged in many low and middle income countries, despite the expansion of NGS infrastructure and expertise due to the COVID-19 pandemic. So countries may actually have the infrastructure, but they're still just not using it. Also, they said that the results that were being reported were mostly for drugs which simpler tests already exist. Right? And so how do we then move into a more impactful use of these assays, such as the B-PALM-M regimen, right? The study actually said that it was unable to determine the accuracy of targeted NGS for this regimen, and so more high-quality data is needed. And we know that some of these more molecular assays don't do as well as phenotypic drug susceptibility testing, so we need to keep that in mind. We need more information on implementation, so not just what is the instrument, but actually how should you implement these into routine diagnostic settings, and differences in test accuracy between the different targeted NGS systems. Just like we know that one molecular system isn't the same as another molecular, the same with our targeted NGS platforms as well. And then, of course, overcoming technical and logistical challenges as well as cost is a must if we want to improve the use of these targeted NGS assays. And investigation on the performance of targeted NGS in other populations, such as possibacillary tuberculosis, such as in children, and also in people with HIV is warranted. So we just need more data. So given these challenges, we need to continue to leverage, of course, other classes of technologies and current testing methodologies that are more accessible and easier to perform. So I know sometimes we focus on how do I get TNGS into my laboratory or into this space, but I would say you really need to look at the entire picture. So it's not how do I get TNGS, but how do I also continue to do phenotypic DST, or how do you bring that on board as well, depending on your burden and your need. And so I hope that this has set a good kind of baseline to hear from all the other speakers that we have today. We have some incredible success stories and best practicings using tools and strategies that are available today regarding implementation experience with these different tests. So thank you very much, and I think I'm going to pass it over to Dr. Budi Hamilton. Thank you.